Hello, today I'm going to talk to you about the basics of wound healing. My name is Yvonne and I'm a third-year medical student at the University of British Columbia. I have made this video with Dr. Janine Roller, a plastic surgeon trained at the University of British Columbia. Our talk today will focus on an approach to wound assessment, the requirements for wound healing, the phases of wound healing, and local and systemic factors affecting wound healing. Let's go over a few definitions. Primary wound healing is when the edges of a wound are reapproximated within hours. Delayed primary healing is when the edges of the wound are closed at 3 to 4 days. The wound strength is the same as primary wound healing. Secondary wound healing is when the wound closes by contraction, mainly a result of myofibroblasts and epithelialization. Non-healing wounds are when a wound fails to close and re-epithelialize within a reasonable time frame, usually 30 days. This is usually a result of local and systemic factors that we will review later in the presentation. The initial step of the wound assessment is obtaining the patient's history. Elicit how and when the wound occurred, how the wound has changed over time, symptoms associated with the wound, and what dressings or interventions have taken place. Noting if radiation has occurred at the site of the wound is also relevant. Review the patient's past medical history, focusing on conditions that affect wound healing, including diabetes, vascular disease, and if the patient is immunocompromised. Review the patient's medications, allergies, and social history, specifically smoking and nutrition. This is an outline on how to describe a wound. It provides consistency in clinical assessments and aids in communication. First, locate the primary wound site and any adjacent or secondary wounds. Next, take note of the wound size, including its length, width, and depth. The simplest method to measure the length and width of a wound is using a ruler. For depth, use a sterile cotton tip swab to gently insert into the deepest pocket of the wound and grasp it at the surface of the wound and measure against a ruler. For wounds with varying depths with features such as tunneling, undermining, or a sinus, it is best to describe the direction of depth within a wound using a clock method. Next, describe the extent and types of tissue involved in the wound. Note if the wound is partial thickness or full thickness. In a superficial abrasion, there is loss of epidermis only. In a partial thickness injury, there is loss of epidermis and dermis. If the wound is full thickness through the skin, it is then important to note what additional structures are involved or exposed, such as adipose tissue, muscle, tendon, or bone. If there are other vital structures, such as blood vessels or nerves exposed, this should be noted as well. Next, comment on the wound edges. It can be well-defined, diffuse, rolled, thickened, fibrous, or scarred. Note if there is tunneling or a connection under the skin from one wound to an adjacent wound, or undermining, which is an erosion underneath the wound edge. Also note the moisture level of the wound. Then assess the condition of the surrounding skin. Note the surrounding skin's color, pigmentation, if the tissue is shiny, taut, or firm, and if there's induration or edema, which can be described on a scale. If the surrounding skin is red, hot, painful, and tender, this may indicate an acute infection. Finally, describe the wound bed and the types of tissue present. Necrotic tissue indicates tissue death and can present as slough, which can appear as thick, yellow, white, or gray material that results from an accumulation of dead cells. It can also present as eschar, which is black, dry, thick, and leathery. Granulation tissue is new connective tissue and blood vessels that form on the surface of a wound during healing. It appears as pink or red moist tissue and is well vascularized. Epithelial tissue appears on top of granulation tissue and appears as pink or white. The wound may have exudate or drainage. This can be serous in nature, which presents as thin, watery, and clear, sanguinous, which is bloody, or purulent, which is thin or thick, opaque, tan to yellow in color, and is often accompanied by a foul smell. Make sure to estimate the amount of exudate and note for odors. There are many classification schemes for wounds. In the operating room, however, there is a standard classification for surgical wounds based on the level of contamination. This is helpful to predict the risk of infection and wound healing outcomes. Wound healing is a dynamic process consisting of three continuous overlapping phases. The events of each phase must happen in a regulated manner. Interruptions, aberrancies, or prolongation in the process can lead to delayed wound healing or a non-healing chronic wound. The first phase is the inflammatory phase, which occurs immediately until day 6. Hemostasis is achieved through vascular constriction and fibrin clot formation. Vasodilation then encourages blood flow, allowing inflammatory cells to then migrate to the wound with sequential infiltration of neutrophils to clear invading microbes, macrophages to phagocytose debris, as well as lymphocytes. Macrophages then switch to a reparative state that stimulates keratinocytes, fibroblasts, and angiogenesis to promote tissue regeneration. The proliferative phase starts on day 4 and can last until week 3. The initial fibrin matrix is gradually replaced with granulation tissue. Granulation tissue is largely composed of 3 cell types: fibroblasts that produce collagen, macrophages, and endothelial cells to promote angiogenesis for a new blood supply to the wound. During this phase, keratinocytes from the periphery will migrate onto the new extracellular matrix scaffold and re-epithelialize the wound. The final phase is remodeling, which starts on week 3 and can last over a year. Under mechanical tension, fibroblasts differentiate into myofibroblasts, resulting in wound contraction. Many of the newly formed capillaries will regress to renormalize the vascular density of the wound. An equilibrium between collagen synthesis and turnover is reached. Over time, the initial collagen-produced type 3 collagen is replaced by stronger type 1 collagen. The wound's tensile strength peaks at approximately 2 months with 80% of pre-injury strength. A few prerequisites are needed for a wound to heal normally. This includes hemostasis, an adequate blood supply, a clean wound base without an active infection, stable wound environment, an optimal amount of skin moisture to facilitate cell migration, and lastly, proper nutrition. Multiple factors can affect wound healing. In general, these can be categorized into local and systemic factors. Local factors are those that directly influence the characteristics of the wound itself, whereas systemic factors are related to the overall health and disease state of the individual that affect his or her ability to heal. Local factors that negatively influence a wound include poor vascular supply, infection, a history of radiation therapy to the area, moisture imbalance, excess edema, pressure, or mechanical stress to the wound, and the presence of a foreign body or cancer within the wound. Systemic factors can be divided into modifiable and non-modifiable. Those listed with a star may be in either category depending on the situation. Systemic factors include genetics, such as tendency to hypertrophic or keloid scarring, and older age. Underlying medical conditions, such as diabetes, venous insufficiency, renal failure, immunodeficiency, can also impair the quality or delay wound healing. Modifiable factors that negatively influence wound healing include obesity, smoking, poor nutrition, and specific medications, such as glucocorticoids and chemotherapeutic agents. Thank you for listening to the talk, and I hope you now have a better understanding of the basics of wound healing.